And bone-level implants were placed in both groups, later restored with screw-retained restorations. And look what kind of results we had. We have the X-rays after placement, 2 months after healing, restoration, 1 year follow-up. And this was in thin tissues, and here we have results in thick tissues. But of course, it's better to compare them looking at side by side. And here you actually can see the difference. And when we calculated, we found statistically significant differences at all measurements. 2 months after placement, restoration day, and 1 year follow-up. So brief summary before we jump now to the real reconstruction of the tissues, that if you have thin tissues, you have problems. If you have thick tissues, you have less problems. Well, then the question is next. So what do we do? If we really think, and if you really have the patient like this, you open the flap, you measure your thickness and you have 2 millimeters or less, then you must do something. You just cannot just place an implant and forget it. And here I want to make a compliment and thank you to my colleague, which has really helped me, and the majority of the cases you will see were performed by him. And together we developed a special chart, how to successfully work in thin tissue burr type. And you can have like bone reduction, subcrestal implant placement, TEN technique, or vertical augmentation. And now let's look at this chart little by little. But first let's decide why is this bone, what bone height is doing here. Because you always have to measure the bone between alveolar nerve and your bone crest. And let's say that this is in order to comfortably place 7 or 6 millimeters implant, you have to have some distance, safe distance from alveolar nerve. So bone height should be, let's say, about 8 millimeters. So if the bone height millimeters is 8 millimeters or more, then you have a lot of choice. First choice, just place implant deeper. And I will tell you that, of course, some of these techniques are not really statistically and clinically really proven, but they have some sort of clinical common sense. What would happen if you do like that? Well, the bone will resorb, because you will place microgap below gingival crestal level, but you will have longer soft tissue contact. In terms, you sacrifice bone for the tissues, but since you have a longer distance to nerve, maybe could be an explanation. The other thing is reduction of the bone. Now let's look, how would we work in this kind of clinical situation when we have narrow implant or wide implant with augmentation? One way to do it is to reduce the bone, to flatten the bone, and to make it better for platform for implant placement. Well, is this really a sound technique? Sometimes we have cases when there have too much bone, like here. If you would not take this bone away, you would have short clinical crown and it would not be aesthetic. Like here, some implant companies even suggest to make a platform for the implant before placement of it, so you can reduce it. And what do we do in cases like this? After extraction, we just do not go straight away to implants. We just flatten the surface and then we can place implants, and that really works. So flattening of the bone actually is not a big problem. Like here, you can see two cases. One, immediate implant placement. The other case was bone reduction and placing implant supracrestally. Now let's follow what happens with the implant. Look here, the bone healing. We already see a little bit of crestal bone loss. And here, this is the restoration and follow-up. You can see around the implant where the bone was flattened, we had a better outcome compared to here. But why is that? Because when you flatten the bone, you actually increase soft tissue thickness. And if we think that soft tissue thickness is a really important parameter, so in this case, we flatten the bone to preserve the bone. And it actually really good, working well. You can see some X-rays after 3 years. Well, what else can we do? Well, we can go for a tent pole technique or some sort of technique when you use you place an implant in two stages and place a healing abutment on top and suture tissues over. Yeah, that's also an option, and it goes like this: you place an implant, a healing abutment, and the tissues are sutured over, and this abutment is holding the tissues like a pole, and all this area is filled with blood, and again it may be reorganized into soft tissue thickness, which is also really needed in these cases. Of course, what is very important over here is that the major flap released. Actually, you must release the flap as much as possible in order to avoid the hindrances of healing abutment. Well, what then if we don't have enough bone? We have like 8 millimeters or even less. When it means that we cannot just place implant deeper, we cannot reduce the bone because the bone is already not here, then we must think of something else. And in 2009 paper, we just stated that finally it's important to consider the thickening of thin tissues before or during the implant placement to thicken them vertically. Is it possible? Is it done? How it would look like? It would look like we place an implant, we put some sort of graft over it and suture it, and this is vertical reconstruction of peri-implant tissues. Was it done before? Yeah, I found the paper in 2010. It was done by Wiesner et al. But what amazed me that they have two groups, a control group and a test group with thin tissues, but the outcome was that soft tissues got thicker, but that did not reduce crestal bone loss. So what was the reason? The reason was very simple. In both groups, implants were placed equally with bone, meaning that the microgap was situated at the bone crest. And I want to remind the etiology of crestal bone instability that there are many factors, and they are working at the same time. So this was the reason why they did not get the results. Another question was, what would we use for that? Do we go for graft augmentation of connective tissue graft? Well, we all know that it's, how to say, golden standard, but not every clinician is able to do it, and of course patients do not like it. So as an alternative, we could think about allogenic grafts, which are also widely used in our profession. And they're being used already for horizontal thickening of the tissues. So why don't we use them for vertical augmentation of the peri-implant tissues? So we made a setup for two studies, and the goal was to evaluate how implants maintain crestal bone stability after thickening of thin peri-implant tissues with allogenic materials. We had 3 groups, and we used the traditional connection implants. All of them were positioned supracrestally in order to isolate 2 other factors responsible for crestal bone instability: tissue thickness measurement and thin or thick tissues, 2 millimeters or less or more. And we have 3 groups. In one group, we just placed implants and placed healing abutments. The second group, in thin bar type, we placed implants and augmented them vertically with allogenic material. And the third group was a control one, was naturally thick tissues, again, so implant placement and with the healing abutments. These 2 groups had 1-stage surgery, while the second group had 2-stage surgeries, because we also wanted to measure how much tissue increasement we were able to get. For that, we used a cellular delmal matrix, and that was the going on of the study. And after 3 months, we made a re-entry, we made the 2nd-stage surgery, and during that, we were able to measure tissue thickness increasement, how thicker it got compared to the primary stage. Well, and again, for X-rays after placement, 2 months after healing, after prosthetics, and 1-year follow-up, just to follow up what happens with the bone. So these were results. After 2 months, we had the significant difference. In thin group already, we have 0.92, while thin with the membrane, we have 1.18, and in thick group, natural thick tissues, we have 0.23. However, the most important is 1 year follow-up, but the tendency remained the same, that in thin tissues we had almost 2 millimeters, in group 2 thin plus membrane 0.32, and in naturally thick tissues we had 0.45 millimeters, and there was a significant differences between the groups. It was statistically significant. The next question is how much tissues were increased in thickness, and that was done quite significantly, almost 2.5 millimeters, and again there was significant differences between the primary and secondary stages. And here you can see that you really by using allogenic material, you can really increase your tissues as much as possible. And look at an X-ray. This is after placement. You can see the volume of vertical tissues. This is after 1 year or 2 year follow-up. Look at the bone level. It was considered impossible that implants with standard platform would be able to hold bone like that. But this is true, this is no Photoshop. And then we made a publication that it's possible to reduce crestal bone loss with the thickening, vertical thickening of the tissues from that number to that number. And doing simultaneously, we performed the study with other material and the platinum switching and bone level implants, and the outcome was the same, that we're able to reduce crestal bone loss from one number to the other. So, to finally summarize the talk, is that if you have thin tissues, you will have problems. If you have thick tissues, the bone loss will be much reduced. However, if you have thin tissues, you use allogenic membrane for vertical augmentations, you will transform your case exactly to the thick tissue biotype. Now, finally, what questions these studies can raise? The first question I usually get is, does it create a pocket? Maybe it's too thick and we have a pocket of a long soft tissue contact. We are running away from the wolf and we get on the bear. But this study, really, by Tomasi et al., calmed me down. They made a histological evaluation, and they found that in a healthy perimplant mucosa in humans, it's 3.8 millimeters. And actually, this is the tissue thickness we got actually after thickening of the tissue. So in terms of the length it's completely normal. The next question is long-term stability. Well, long-term it's a debatable question. What is long-term? So far we have a 3-year result, and we have a paper upcoming and process. Yeah, you can clearly see that in these augmented tissues, the bone stays the same. Even here, you can notice decoctalization.